The focus of this talk is on obesity definitions and classifications. Now, for those of you who attended my talk earlier this afternoon, I spoke about the fact that the Canadian Medical Association, like many other organizations, have now recognized obesity to be a chronic medical disease. But there is a problem with recognizing obesity as a disease, and that has to do with the use of BMI. So in their declaration of obesity as a disease, the Canadian Medical Association did highlight the fact that although body mass index is the usual operation definition for obesity, it should not be used as the defining characteristic of the disease. And so in my talk today, I want to focus on what the limitations of the use of BMI are, and also leave you with some suggestions on how you may be more effective in defining obesity in a slightly different way. Now, as you know, the body mass index, which has been used to define obesity for a long time, was never developed for clinical practice. It was actually just a statistical number that describes the relationship between change in body weight and body size. So really, it is a measure of body size. It's not really a measure of body fat. It's not a measure of anything else. And it's most certainly not a measure of health. The most common example that is used to show that BMI is not a direct measure of fat is actually this slide, which shows two individuals, a European person and a South Asian person. And as you can see, the BMI of both individuals is pretty much the same, it's 22.3. But when you look at body composition here in terms of body fat, this individual has 9% body fat, this individual has 20% body fat. So that's a twofold difference in body fat and exactly the same BMI. And when you look at the overall relationship, statistically, it's a very significant correlation between body mass index and body fat. But in clinical practice, when you're dealing with individuals, it's not a very good diagnostic criteria. So, for example, if you're looking at a man with a BMI of, say, 30, that person can have 10% body fat or have 50% body fat at a BMI of 30. That's a five-fold difference in body fat. So it's not an all-precise measure of the amount of body fat. Even in women, at a BMI of 30, you can have 30% body fat or you can have 60% body fat. So that's a twofold difference in body fat. So we have to remember that body mass index doesn't actually measure body composition or even the amount of body fat. In an individual patient, in fact, body mass index tells you very little about that person's body composition. Now, in addition, we know that it is not the total amount of body fat that matters from a health perspective, particularly if you're looking at metabolic health, but it's rather the location of the fat and the kind of fat. So one of the things that we have learned is that although you might have a lot of fat in your body, as long as that fat is located in your subcutaneous stores, you can be metabolically healthy. It is only when the fat gets stored in internal organs, and we talk about visceral fat, or you have fat that's located directly in the skeletal muscle or endocardial tissue, or of course in the liver, that's when people develop metabolic syndrome or start having metabolic issues. This, of course, is also not measured by BMI. BMI does not tell you anything about fat location. It doesn't tell you anything about the kind of fat. It doesn't tell you anything about the similarity of fat. It does not tell you anything about whether there is an inflammatory response in your adipose tissue. So none of that information is available in the BMI, which leads us to the fact that BMI is really just a measure of size. It's not a measure of health. The fact that BMI does not even predict mortality, or changes in BMI do not predict mortality, is something that we've learned from bariatric surgery studies. As you know, bariatric surgery is the only effective way to get somebody to lose a significant amount of weight long enough to study the impact of mortality. And when you look at the bariatric surgery long-term cardiovascular events, there is no doubt that bariatric surgery will actually significantly lower cardiovascular mortality. But the interesting finding in this study was that there is virtually no relationship between baseline BMI and reduction in cardiovascular risk, or even the change in BMI and reduction in cardiovascular risk. Those are almost two things that are independent, which means that there are people who have lower BMI who get benefit from bariatric surgery, and there are people who don't lose a lot of weight with bariatric surgery, but still benefit from bariatric surgery. So there's not a lot of relationship between what actually happens to BMI, or what the baseline BMI is, and what the Because of this dilemma, a few years ago we came up with a new classification system for obesity that was really based on the presence of other risk factors or the presence of comorbidities. And we proposed this clinical staging system, and because I'm based in Edmonton, this system has now become the Edmonton Obesity Staging System. It's actually a very simple system that can be used in any clinical context. And the idea here is that when you have somebody who has obesity, based on whatever BMI definition you use, you will find people where when you look at their medical problems, you look at their metabolic problems, you look at their mental health, and you look at their functional health, they do not seem to have any problems at all. They're large, they may not be happy with their weight, but they are, any test that you do, whether you measure blood pressure, whether you look at the lipid profile, you look at the insulin, diabetes, whatever test you run, it comes back as normal. So we propose that we call that stage 0 obesity. Then of course we will have people who will have some preclinical risk factors. And we propose that you call that stage 1 obesity. And once people have an accompanying comorbidity, it doesn't matter what the comorbidity is, we consider that to be stage 2 obesity. If the patient has clinically relevant end organ damage from the comorbidity, we consider that to have to be stage 3 obesity. And if the patient has irreversible end organ damage, so if you have problems that are probably not going to be reversed even with weight loss, then we consider that to be stage 4 obesity. So just to give you an example of how the system works, if you're considering, for example, glucose metabolism, or take hypertension first. So someone with normal blood pressure would be stage 0, pre-hypertension stage 1, hypertension stage 2, left ventricular hypertrophy, coronary heart failure would be, or coronary artery disease would be stage 3, and if the patient has heart failure, we would consider that to be stage 4. Or you take diabetes, normal blood glucose, impaired fasting glucose, impaired glucose tolerance, type 2 diabetes is stage 2, micro or macrovascular disease, and then end stage would be end-stage renal failure or blindness or amputation, etc. So you can take whatever comorbidity you want and you can stage the patient based on the Edmonton Obesity Staging System. So what we did then was to take the system and apply it to large population samples to see whether there is a better prediction of outcomes based on this type of classification. And so I'm just going to give you one example where we use the enhanced data set, which in the US is a very large population-based data set, where you can link baseline data to mortality data over long periods of time. And in one of the data sets where we use the NH3 data, we had a 200-month follow-up, which is almost 18 years, so basically 20 years of follow-up, and where you can look at mortality. So what you see on this slide is the relationship of the different BMI categories. So we're talking about overweight category, which for the Europeans or the US would be BMI 25 to 30, stage 1, class 1, class 2, class 3 obesity, only based on BMI. And what you're seeing here is survival curves over 20 years. And as you can see on the slide, there is really no difference between the different BMI classes. So what this means in practical terms is if you call my office and say, Dr. Sharma, I have got a patient here with BMI 35, what is his prognosis? I can tell you I have no idea. It could be anything. On the other hand, if you take the same data set and you classify people based on the Edmonton Obesity Staging System, it looks very different. So when you look at the blue line, those are people with stage 3 obesity. Half of them will be dead within 20 years. When you look at the green line, this is people with comorbidity, so that is stage 2 obesity. About 25% of those people will be dead within 20 years. I draw your attention to the black line. Those are people who have obesity based on BMI, but they're stage 0, which means that they're essentially healthy. These people can go for 20 years with almost no increased mortality at all. And this is true for every BMI class. So if you look at all the different BMI classes, it's always the same pattern. If you have a comorbidity or if you have end organ damage, then you're in the high risk group. If you are otherwise healthy, then you are in the low risk group, irrespective of what your actual BMI is. Now this has particular relevance, I believe, especially for the Indian population, where you're not going to see a lot of people with very high BMIs unless you're running a bariatric center, where the average BMI is going to be in a much more lower category. So what is important here is to know that even in low BMI level, or people that we consider to have normal BMI, this will actually predict mortality. Now we have done a study in Canada where we looked at the relationship of metabolic problems in South Asians living in Canada who don't meet the BMI criteria for obesity, which we would normally see in Caucasian people. So these are people with BMIs below 25. Even in those normal populations, what we found was that the South Asians, they tend to have more visceral and ectopic fat, they tend to have larger adipocytes, they tend to have higher fasting insulin, they tend to have higher HOMA index, higher triglycerides, and lower adiponectin levels when you compare them to Caucasians who have the same BMI. So we know that the South Asian, or people of South Asian origin, are much more predisposed to getting metabolic problems, even at a BMI that would be considered normal or low for someone who's Caucasian. And so, when we look at the data on the obesity staging system, for people in the BMI range of 25 to 30, which would not be considered to have obesity, you can see that the endocrine staging system also exactly predicts who is going to have high risk. So what you see here are just the overweight people, so we're talking BMI 25 to 30, and you can see the same result. If you have an organ damage, half of these patients will be dead within 20 years. If you don't have any measurable obesity-related health problem, blood pressure normal, triglycerides normal, no problems, no other health problems, then your prognosis is actually very good, irrespective of what your BMI is. So, having said that, this system of classification that is not based on BMI, but is based on the actual health status of the patient, has now been adopted in several different guidelines. So in Canada, we have the 5 Ways of Obesity Management Guideline, in which we recommend, of course, that you also assess the individual obesity-related risk in every patient before making a decision. And so, we don't just measure BMI, which tells you how big your patient is, but it's also important to measure EOS, which will tell you how sick your patient is. And because in every treatment option you're looking at risk-benefit ratio, it is important to look at the actual risk of the patient, and BMI does not give you that information. I was also quite happy to see that this system is now also been adopted by the American Society of Bariatric Physicians, which is now called the American Society of Obesity Medicine. And in their algorithm, also you will find that the endocrine obesity staging system is now included as a risk stratification scheme. So, in summary, for this part of my talk, it is important to recognize that BMI does not tell you much about the health of your patient, and probably should not be used as the defining characteristic of obesity. Now, having said that, I want to share with you some data of where the endocrine obesity staging system can also be used, apart from simply classifying obesity. I want to share first of all with you one study that came out of Germany. This was a study that was done in bariatric patients. And they looked at the relationship of 30-day post-surgical mortality in patients who underwent bariatric surgery. And I apologize that the numbers might be difficult to read on this slide. Basically, this was a study of 500 patients who had bariatric surgery, who were classified by whether they had EOS 0, 1, 2, 3, or 4. And as you might expect, most of the patients actually were in the EOS 2 and 3 category, which makes sense because those are the patients who normally undergo bariatric surgery. The first thing I want to point out is that if you look at the BMI levels across all 4 endocrine obesity staging system categories, it's basically the same. So every EOS class, the BMI is about 50. There's no difference. But if you look at the complication rate of 30-day complication rate of bariatric surgery, in EOS 0 patients, the complication rate was basically 0. That increased to 2% for EOS 1. It goes up to 8% for EOS 2, jumps to 22% complication rate for the EOS 3 patient, and they had one patient in EOS 4 and that patient died. So that was 100% complication. So you see a very strong relationship between the EOS class and the post-surgical risk, irrespective of BMI, because BMI was the same in all of these, in all 5 groups. Now, this was a study that was done in bariatric surgical patients. but I'm quite confident that if you did this study in any kind of surgical patient, whether you're looking at cardiac surgery or knee replacement or probably even gallbladders, you will see that the relationship of the risk for the patient is not related to the patient's BMI, but will always be related to what is the EOS class of the patient. So I think that the EOS system can also be used as a risk predictor for surgical systems. Now this is bariatric surgery, and I'm quite confident that in most cases of any kind of surgery, EOS will be a much better predictor of outcomes than body mass index. So this is another use of EOS. I want to share with you one more use of EOS, which is also from a study that was recently done. And this is in an area that you might not be so engaged in, and it has to do with fertility treatments. So in Canada, like in many countries, there is a restriction of providing fertility clinics, fertility treatments to women with higher BMIs. And in fact, in the Canadian guidelines for fertility treatments, there is a limit on the amount on the BMI at which you would provide fertility treatments for women. And this has to do with the fact that there seems to be this idea that people with higher BMIs have a lower success rate with fertility treatments. So we looked at this prospectively in 500 women, and what we saw, 100 women, and what we saw there is that there does not seem to be a very strong relationship between the success of fertility treatment and BMI levels. So here you're looking at 4 different BMI categories. You've got overweight, type class 1, class 2, class 3, using the Caucasian definitions. And as you can see, the average success rate of fertility treatment was about 20 to 25%, which means that about 1 in 4, 1 in 5 women will have successful treatment for fertility across all BMI ranges. If you look at the same people, based on the Edmonton obesity staging system, the picture looks very different. Now, if you have a woman, irrespective of BMI, if she's metabolically healthy, your success rate of fertility treatment will be almost 50%. 1 in 2 women will get pregnant. If it is an EOS 2 score, which means the patient with comorbidity, that drops to about 20%. When you have a woman who has EOS 3, your success rate for fertility treatment is almost 0. So this is another potential use of the Edmonton obesity staging system, which is a better predictor of success of fertility treatment than just using BMI alone. So these are just 2 examples of how that actually support the idea that simply taking people's BMI and making clinical decisions based on people's BMI is probably not the most sensible thing to do. So how does this affect our definition for obesity? And we recently wrote an article on this. It was published in Obesity just about a month ago, where we proposed making a change to the obesity definition that has been used by the World Health Organization for many years. If you go to the World Health Organization website, you will see that the definition of obesity there, this definition has been there for many, many years, is the presence of abnormal or excess body fat that may impair health. Now the problem with this as a disease definition, of course, is the word may. Because may means it may or it may not. So if you have somebody who has excess body fat, but they don't have an impairment in health, then how can you call that a disease? Because a disease requires that you have an impairment in health. So what we propose is changing the definition of obesity to be that obesity is the presence of abnormal or excess body fat that impairs health. If it doesn't impair health, it is not obesity. If it impairs health, it is obesity. So I think in our rethinking of obesity, we have to recognize that body mass index itself is not a good measure of health and should not be used as the diagnostic criterion for defining obesity. Rather, when we think about obesity, we have to look at the actual health of the patient, we have to look at the actual health impairments. And there we know that the Edmonton obesity staging system is a much better predictor of outcomes and risk of the patient than BMI. And therefore, we also believe that the Edmonton obesity staging system provides a very rational framework for clinical prioritization and management and indications for treatments for patients presenting with abnormal or excess body fat. And we believe, or we propose, that the definition of obesity clinical definition of obesity should be changed to be that it is an impairment in health which is attributable to abnormal or excess body fat. Only when you have an impairment in health do you have obesity. Having excess body fat alone is not enough to define obesity. And so that is a proposal that we are putting forward, and we're seeing that there are similar proposals that have been coming from the American Association for Clinical Endocrinology, who are also suggesting that we should only diagnose obesity in somebody who actually has a demonstrable health impairment